Okay. Hi guys, welcome and thank you so much for joining us today. We are Pre-Health Shadowing, an international nonprofit organization, and our mission is to empower aspiring healthcare professionals by providing virtual shadowing opportunities like this one. And we are thrilled to have you here today as part of our community, and your participation and support are crucial in driving us forward in our shared goals in the medical field. As part of our commitment to inclusivity, we also provide closed captions to support students of all abilities and needs. We value your feedback and are always looking to improve accessibility. So if you have any ideas or suggestions, please feel free to email us at info@prehealthshadowing.com. We're on Instagram at PreHealthShadowing, and if you're on TikTok, we're there too, and you can find us there with the same handle. So don't forget to sign up for our email list because it's the best way to ensure that you're always informed about our latest sessions and opportunities. We are also thrilled to welcome students from all around the globe, and it's always fascinating to learn where everyone's coming from. So, for example, me, Manasvi Sharma, am located in San Jose today. So feel free to share in the chat where you guys are calling from today. Let's see, Los Angeles, Virginia. Ooh, lots of Virginians. San Francisco, New Hampshire. Thank you guys. All right. Apart from this, if you're interested in being part of pre-health shadowing, we have a fantastic opportunity to join us as a volunteer. And volunteering with us is completely remote, so you can contribute from anywhere in the world. And to get started, you can just register on our website to gain valuable experience and make a positive impact in the pre-health field. Apart from this, we're also recruiting for our leadership team and it's open to everyone. So this is your chance to apply your skills, learn new ones, and make a real impact. And you could do all this from the comfort of your home as it's 100% remote. So for this, just head to our website and fill out the application form. Some of the available leadership roles we have right now within pre-health shadowing are listed over here, and we are looking for leaders in all these departments. But you could also propose your own new department or role if you feel like it can holistically help PHS. So yeah, if any of these roles resonate with you, I encourage you to use the link over here to join our team. Our high school training program, or HTP, is another fantastic way to gain valuable skills and insights in both leadership and healthcare field in high school before you step a foot into the college campus. And for this, all you need to do is fill out the interest form available on our website. Apart from this, our entire operation relies on generous donations and the invaluable time contributed by our volunteers at PHS. And this is what allows us to continue offering these opportunities to learners from all backgrounds and walks of life. So if you have the means, please consider making a donation. Every contribution, no matter the size, even if it's like $1, helps us maintain and glow in this inclusive educational experience. Feel free to type any questions you have throughout the session in the chat because we want this to be as interactive and informative as possible. So please don't hesitate to participate. And Dr. Carter will be pausing in between her sessions just to see if you have any questions. After completing the session, you'll also have the opportunity to earn a digital certificate. So please don't forget to take good notes as this is going to allow you to perform well on the certificate quiz. And lastly, if you guys could turn on your camera, that would be really great too, because this approach aims to replicate more of like an in-person environment, so just enhancing the experience overall. Now, I'm pleased to hand things over to our professional guest, Dr. Carter, and we'd just love for you to share a bit about yourself and take it from here.
Thank you so much. I'm excited to be with all of y'all this evening to discuss the profession of clinical pharmacy. So, my name is Jessica Carter. I am originally from East Texas, and I married my high school sweetheart, who is also a pharmacist with me. And I graduated from Texas A&M University in 2016 with my Bachelor's of Science in Biology. And from there, I went to Harding University College of Pharmacy, where I graduated with a PharmD degree in 2020. So, yes, that was the year of COVID. It was a very strange year. And from there, I completed a 1 year postgraduate residency program at a health institution back in East Texas. I stayed on there as an anticoagulation pharmacist and and then I joined faculty at Harding University College of Pharmacy about 2 years ago at the beginning of 2024. I have two boys with my husband. They are amazing, and I enjoy both the professional aspects of pharmacy, but also seeing those aspects bleeding into my personal life for sure. So let's get started with talking about clinical pharmacy. Maybe there's a delay. Okay, so this is what we'll be discussing tonight. I will go over kind of an introduction of pharmacy, and then, oh man, this thing is going crazy. It was not doing that earlier. Okay, I'll provide a little bit of an introduction of pharmacy, my definition of pharmacy, and the dictionary definition. Then we'll go over some background and history of pharmacy as our roles are constantly evolving. Then I'll go through a typical day in a clinical pharmacist in both my previous roles and my current role as an academician. We'll talk about some patient cases, and I even grabbed some things from the clinic today that I hope we can do a little bit of demonstration. We'll talk about how to become a pharmacist, what education is needed, and what extracurricular items might look good on a resume or an application to pharmacy school. Then, what admissions look like. What is our admission process, prerequisites to take? And then I have an exciting internship opportunity I'd like to share with y'all at the very end. So, to introduce our topic of clinical pharmacy, a pharmacist is a person who is professionally qualified to prepare and dispense medicinal drugs and advise on their use. My personal definition, as most pharmacist definition, is actually just the drug expert. We are expected to know everything about prescription medications, over-the-counter medications, and even natural medications such as supplements and herbal medicines that you can put in your body. I'm super passionate about understanding how medications work and why someone is taking them. So it's one of my favorite parts of my job is to explain this information to a patient who may have a laundry list of medications and they just are taking them because my doctor said so. So pharmacists can really step in and play a huge role in educating patients and informing the public of about their medicines and about their disease states. So, a little bit of background and history in the area of pharmacy is I said earlier that pharmacists are expected to be drug experts. So, this began in ancient times. If you read the Bible, there's interesting ancient practices that are even mentioned in the Bible. So, this is like um, before Christ's times using natural sources. So those in Egypt have been known to write down the very first kinds of medicines they've used. But really, the father of pharmacy was someone named Galen, and he was who figured out the chemical aspects of mixing different medicinal natural sources and actually coming up with kind of what we consider compounding pharmacy today. So in the picture I have here, it's a mortar and pestle, and you can see that herbs and other things are being ground up. These are going to be mixed in different proportions to best make a good medicine for something that's not allowed on the market. And that is where the Industrial Revolution came in and changed pharmacy a whole lot. So when pharmacy first began, it was a whole lot of hands-on compounding. We had to derive the natural sources from things and make the medicinal components available. But in the Industrial Revolution, this was done on a huge scale, just like everything else was in the United States. So, based on that, uh, manufacturers were able to develop, synthesize, and produce medications on a mass scale, making pharmacists a more dispensary role. So we would receive the medications from the manufacturer and dispense them to the patient based on prescriptions. However, in recent years, maybe as early as 1970, there has been a much bigger expansion of pharmacy roles into what I call clinical pharmacy. So, clinical pharmacy is where we are able to do a whole lot more than just dispense medications. While we are still going to count pills, make sure the prescription's covered by insurance, and make sure that a patient has enough for a month's supply, we're also potentially going to make recommendations on starting a new medication, adjusting dosages to medications, or even switching medication to something completely different based on other past medical history and the background of the patient. So, over the last decade and 2 decades, we've seen a huge boom in clinical pharmacy because of this expansion. In order to become a pharmacist, there is some education that has to take place. So, in your undergraduate coursework, the most prerequisite courses required are about 2 years worth of coursework. So our particular program at Harding University's College of Pharmacy, located in Searcy, Arkansas, is 64 hours of prerequisite work, with math and science making up a bulk of those hours, and general education making up the other part where math and science do not fall in. So now that I've talked briefly about the background of a pharmacist and briefly on the education a pharmacist has before going into practice, let's talk about the three major types of pharmacy and what a typical day might look like in those. So I classify the three main types of pharmacy as community, hospital, and ambulatory care. Community pharmacy is most likely what most of you think of whenever I say the word pharmacist. And this is someone like in a chain pharmacy store, a grocery store pharmacy, or your local drugstore that has been there for your whole life. So your community pharmacist's typical day looks more like a dispensing pharmacist, but there are some expansion roles in that as well. So a typical day would be receiving a prescription. Most of our prescriptions are received electronically. You can kind of envision this like an email in some ways, where you open this up and a prescription pops up onto the screen, and your prescription has multiple parts that we want to focus on. So we're looking at the medication name and the dosage that the doctor prescribed, as well as the instructions with that medication. So take one tablet once a day or take one tablet twice a day, as well as the duration of therapy. So is this going to be a medication the patient will be on forever or chronically? Or is this going to be a short-term medication like an antibiotic? So that is some of the mechanics of putting in a prescription. While you're inputting a prescription, typing it up into the system to create a label that goes on the bottle, there's also some other cool things that are running in the background. So some of these things are like drug-drug interaction checks. So many medications cannot be taken safely together, or they need to be separated, or they have certain instructions to lessen that drug-drug interaction. So a drug-drug interaction might pop up, and that retail or community pharmacist has to evaluate the pertinence of that drug-drug interaction and decide whether or not it is safe for the patient to go ahead and receive this medication, or if the pharmacist needs to intervene and discuss this interaction with the healthcare provider, such as the doctor or the nurse practitioner who wrote the prescription. After all of that is resolved, or if the prescription is validated as safe to take, then that medication, it prints out a label which shows the pharmacy technician or a pharmacist which medication to actually dispense. So I, in my nativity, whenever I began pharmacy, I didn't really understand what the bottles looked like in a pharmacy. I had only just received an amber bottle with a few pills every once in a while before I went to pharmacy school. But in a pharmacy, there's huge bottles of that are sent to you from the manufacturer. So these are bottles that have like 500 pills, sometimes 1,000 pills, and it very rarely do you have more pre-packaged monthly supply pill bottles. So after that medicine is labeled, you have to count out how many pills needed to be dispensed, because we're not going to give a patient 500 pills of something, right? I mean, it's possible, but very rare. That would be a red flag. So we would count out the medication and put it into the bottle, and then we would add anything called ancillary labels to that bottle. So if you've ever picked up a prescription and you see this little red label on the bottle that says take with food or stay away from sunlight or avoid milk or dairy containing products. Those were put on by the pharmacy technicians or the pharmacists when they realized what medication they were putting into that bottle. Then the pharmacist is going to be your final check. So if a pharmacy technician is the one who filled that pill bottle, the pharmacist is going to double check to make sure that that medication dispensed was the correct one and it looks to be the correct amount and it was in fact what the prescriber prescribed. And then the last final step is to educate a patient on that medicine. So in the state of Arkansas, it's actually required by law that we counsel on every prescription and at least offer counseling on every prescription that leaves a community pharmacy. Meaning we have to discuss the benefits of that medication, how to take that medication, the risks of taking that medication, like side effects or black box warnings, as well as verifying their understanding that the patient truly understands how to take that medicine and that they'll take it correctly once they go home. So this is where my life as a professor comes into play, because I get to coordinate our communications course where I actually get to teach first year pharmacy students about patient counseling. And so some of y'all might be thinking, why do I need a class on patient counseling whenever I'm going to know all the things about the drugs? Well, it's true. You will know all the things about the drugs, but we have to be able to communicate that to our patient in order for the patient to have the best outcomes. So things like using patient-friendly language, asking open-ended questions instead of yes or no questions to allow that patient the opportunity to actually share their story. And as well as just maintaining and establishing a trusting relationship with that patient. So being a community pharmacist is really awesome, and there's a whole lot of impact that our pharmacists have in the everyday lives of our patients. I unfortunately only have experience in a community pharmacy as a pharmacy intern during my time in pharmacy school, where I got to observe pharmacists and doing all of these things that we've talked about. So, inputting prescriptions, counseling on prescriptions, calling doctors' offices if they notice something's wrong, and making a huge impact there. Where I do have the most experience is in hospital and ambulatory care pharmacy. So, in hospital pharmacy, a lot of people kind of forget about these people unless they are actually in healthcare. So, in the same way, a hospital pharmacist is going to dispense a medication order that was prescribed by an inpatient physician or hospitalist. So, it works in the same way where a physician or a prescriber prescribes a medication order, and the hospital pharmacist receives that and verifies it in the same way. So, we're still looking at all of those same things, the name of the doctor, excuse me, the name of the patient, verifying that's who it's meant for, the dose, any drug-drug interactions, and there's lots of other things that can happen as well. Um, Hospital pharmacists have kind of two different roles as well as dispensing. They also might be involved in more clinical interventions, such as participating in inpatient rounds. So they get to go on interdisciplinary rounds with the physicians where you're rounding on the patients and you're making recommendations such as dose adjustments or new therapies and sometimes even education. So being a hospital pharmacist is really great. What I like to say is that the community pharmacy aspect, if you really like to talk to people, you really like the public, that's a really great place for you to be. The hospital pharmacy can be a little bit more quiet, and the people that you're actually talking to would be other healthcare members, like nurses, physicians. You may not be actually speaking to the public or your patient as much, and you will likely be doing more chart review instead of actually talking to that patient. So, this is where ambulatory care comes in, and I think this is the best of both worlds. This is where a majority of my experience is. And you may be wondering what ambulatory care means, because whenever I first heard this term, I immediately thought of ambulance. It is not an ambulance at all. It just means your patient is able to walk or ambulate, and it is in an outpatient clinic setting, most typically. So I work in a family medicine practice clinic right now, managing diabetes care. So we get to adjust insulin and prescribe medications for diabetes, hypertension, and hyperlipidemia. Before this, I got to be in a cardiology clinic managing anticoagulation and actually getting to prescribe warfarin as well as other blood thinners that patients get to take. So not only would I get to use my clinical side where I'm practicing guidelines and and getting to speak to patients about what their care is going to be like, I also get to talk to physicians. So it's really just the best of both worlds that I think is a really great opportunity for pharmacists. So before I move on to some patient cases, I want to open it up for a few questions. So what questions do y'all have about a typical day in the different areas? Oop.
I didn't have a question about the typical day, more of about your life. So, what initially kind of drew you to pharmacy over other healthcare fields? And like, was there something like a specific moment or experience about your
Yeah.
decision?
Yeah, that's a great question. So I do cover this a little bit in a slide, but this is perfect. So I always knew I wanted to go into healthcare. Whenever I was growing up, I loved science. I loved learning about the body, watching how, like seeing God's design in our bodies and seeing how we can treat that. So I originally thought I wanted to be a dentist, and I went to my first semester of undergraduate work, and I was like, I do not want to be in school for 8 years plus and and then still possibly need training. I also like the mouth is really small. It has a big impact, but I was really interested in more the whole body. So I kind of switched, I didn't switch majors per se, but I kind of changed tracks. I was always a biology major, and I was thinking that I wanted to be a physician assistant after that. So to be a physician assistant, you have to have a lot of direct patient care hours. And in those direct patient care hours, I did a lot of volunteering at a local hospital and clinic. And I realized I did not actually want to touch people as much as a physician assistant possibly would be assigned to do. Um, I still enjoyed the aspect of care and what they were doing, but I really wanted to be in a more ancillary role where I wasn't expected to, dress the wounds um, or cut someone open. I decided that was not for me. And so it wasn't until my sophomore spring, or yeah, my sophomore spring, I was taking an immunology course at Texas A&M, and I loved it. I like it was amazing. Your immune system, if you haven't taken immunology or some aspect of immunology yet, highly, highly recommend. Super fascinating how your body is already designed to fight off infection, fight off cancer. And then my immunology professor would note things like this thing in your body, this antibody or this receptor is mimicked by a drug that we can use that same process and either block a process or initiate a process, depending on which disease state we're doing. And she connected it so well with pharmacology. And so seeing that we can make a huge difference by mimicking God's design or looking at or giving natural things or synthesized molecules to make a huge difference without necessarily touching a patient. I could still have a huge impact in patient care. So that was really kind of the turning moment for me. I mentioned that I'm married to my high school sweetheart. He was always pre-pharmacy, and so I think that's probably another reason why it took me so long because I wanted to do something different than him. And then after that immunology course, I kind of remember a time where I was like, I'm sorry, I'm going to do this too. And it was actually a really great decision. Going through pharmacy school, somewhat together was a really awesome experience. Good question.
Yes, thank you for that. And I see Jennifer has raised her hand for another one.
All right, I had a question about your practice. Since you said you manage patients with type 2 diabetes and hyperlipidemia, sorry. How have you seen GLP-1 receptor agonists influence patient outcomes and how the mechanism of action, like the delayed gastric emptying, enhancing glucose-dependent insulin secretion and appetite regulation, translate into how their outcome? Do you see a lot of benefits as far as outweighing the side effects that these medications can have?
That's a great question. So, yes, I do primarily work with patients with type 2 diabetes right now. And so the pathophysiology of type 2 diabetes, as I'm sure most of you are aware, is insulin resistance. So there's two major types of diabetes that we talk about. Type 1 is more so a complete lack of insulin. The pancreas, the beta cells in the pancreas are no longer making insulin. That's more of an autoimmune process. Whereas in type 2 diabetes, our patients are making insulin, they just aren't listening to it. So we have lots of different medications at our disposal to help our body listen to the insulin even better. And our GLP-1 receptor agonists, I call them GLPs because it's just really a lot easier for me to say. But that confuses some people. But it's GLP-1 receptor agonists, such as like semaglutide or dulaglutide. These medications have that we call it mechanism of action. They have lots of different mechanisms in their action. So they do delay gastric emptying, so they slow the gut down so that your body does not absorb as much glucose. And then it also is going to work on the satiety center in your brain so that it actually helps you feel fuller. And and decreases the amount of food noise our patients experience, especially if they are struggling with obesity. So I have seen great outcomes with these medications and A1C lowering. So our um, diabetes efficacy or diabetes measures that we're going to look at include hemoglobin A1C and or our time in range if they're wearing a CGM, a continuous glucose monitor. Um, and both of these things, it's just amazing what these medications can do. Like Jennifer said, they do come with risks, and I have seen several of those risks play out. However, most of my patients benefit more from them than those that suffer those risks. And most of the time, those side effects are overcome with time, or we can change them to a different GLP-1 that's maybe less potent, or something is might be slightly different with their chemical structure to limit those side effects. Um, that's all I'll say for now on that. Great question. I love that question. I think someone else had their hand up.
Yeah, I think Justine had her hand up.
Hi. Yeah, I had a separate question, but I think I also saw Jennifer have their hand up, and I just want to know like if Jennifer has like a follow-up question for the first one, so she can go first.
Sorry, it was an accident.
Okay. Perfect. I just had a similar question to the first question that was asked about um if there was a specific experience that made you decide on the type of specialty that you work for today, such as the diabetes, women's health, and anticoagulation that you mentioned before.
Yeah, great question. So during pharmacy school, I should have done a better job of explaining this. So during pharmacy school, it's typically a 4-year program, but there are some 3-year programs, and Harding's is a 3.5-year program. So it's the only one in the nation that's 3.5 years. But during your first 3 years of curriculum, it actually takes place in a classroom. So you're in a classroom most of the time, you're learning from lectures, and then you're only occasionally in a pharmacy. So we call them introductory pharmacy practice experiences. So we kind of introduce students, or I was introduced to these slowly throughout those 3 years. So during pharmacy school, I actually came in with zero pharmacy experience. I came in with a lot of direct patient care experience from my undergraduate volunteering, but I had never actually set foot in a pharmacy. So I did a community pharmacy rotation, an introductory community pharmacy rotation, and I was like, this is really cool. I like this, but it's a big learning curve because there are certain things that happen in a community pharmacy that are they're out of our control. So, insurance programs, for example. So insurances will say, we will cover, let's just talk about GLP-1s. We'll say they cover only semaglutide. So if a doctor prescribes dulaglutide, that insurance program isn't going to cover it. So I would have to be the one to explain to the patient, hey, this isn't going to work. We're going to have to switch it. And I haven't had a chance to call the prescriber yet. And it can be a lot harder to see that impact at a time. So, but I did really appreciate how much drug knowledge that you can use in a community pharmacy and dispensing. But I didn't really love the insurance aspect of that. So then during my first year of pharmacy school, after I'd done some community pharmacy rotations, I got a job in a hospital pharmacy as a hospital pharmacy intern. And I worked every other weekend there, and I absolutely loved it. It was a really great environment. It was completely different than community pharmacy. And I got to be a part of dispensing intravenous medications, so compounding IV medications. It's a completely different way than we picture non-sterile compounding, like the mortar and pestle. It's nothing like that. It's you're in like full-blown PPE. You use something called a vent hood and something called aseptic technique in order to minimize the microbial growth that could happen. Um, and then you also are making those clinical impacts. So physicians give you kind of authority on prescribing certain things or monitoring certain medications. So I had a really, like I said, it was a really great environment. And my pharmacist there during pharmacy school really pushed me and showed me what all was possible in hospital pharmacy. So from there, I took those two experiences and decided to do a postgraduate year of residency in pharmacy. So there are different kinds of residency programs, but I decided to do a general pharmacy, which exposes you to hospital pharmacy, ambulatory care, as well as like other specialties. And in that residency program, I still love hospital pharmacy to this day. I still would like fill in PRN, but I was exposed to the warfarin clinic for the first time. And the warfarin clinic, it's a blood thinner. Warfarin is a blood thinner that you have to get monitored at least once a month most of the time with a lab value. And the ambulatory care pharmacists had a collaborative practice agreement. So they could not only were we monitoring the drugs and making recommendations, but we were actually sending in prescriptions to the pharmacy and completely like we held it all. So from there, I was actually offered a position to stay on in the warfarin clinic, and I love the feel of the ambulatory care clinic because it is your own. So all of the clinics I've been a part of have been pharmacist-led. So the physician or the typical healthcare provider that we think of, like a primary care physician or the cardiologist, would send a referral to the pharmacy clinic. And depending on the level of that collaborative practice agreement determines the level to which you can practice. So it's kind of commonly said that ambulatory care is where you can practice at the top of your pharmacy license. So we can really truly take all of the clinical expertise that we've learned and gained in our pharmacy school and our pharmacy career and actually put it into practice. Um, and I still get my patient interaction, but most of the time it's a positive patient interaction. And instead of sometimes in the community setting, you may have that angry patient who's mad at you for the insurance not covering what they thought was going to be covered and all of that. Um, but you get to create relationships with those patients. So I had uh, my youngest son, I had him whenever I was working in the warfarin clinic. So everybody, he actually he was a NICU baby. So everyone by the time that I got back to work, they were like, "Hey, how's your baby? How's he doing?" And it just really creates this family-like feel, and I just love that. So I can call my patients today at my practice site, and I'm like, "Hey, this is Jessica." And they're like, oh, hey, like, are you going to Texas for Thanksgiving? And I'm like, yep. And it's just such a really cool relationship that you can have with your patients and your providers that are with you in the clinic as well. Any other questions?
Thank you so much for your answer, Dr. Jessica.
Yeah.
I see another question in the chat from Angelina. It says, "What are the day-to-day expectations for you?"
So my day-to-day expectations are a little different now that I'm in academia. So I do practice in ambulatory care. So I try to spend about half of my hours there. So sometimes that looks like going to the clinic in the morning or the afternoon. And then the other half of that time is spent teaching. So I actually, like I mentioned, the communications course that I teach, or I lecture based on expertise. So on topics such as diabetes, hyperlipidemia, women's health, those are the topics that I get to teach about in the classroom and come up with scenarios and patient cases that can help better educate our future pharmacists. Good question.
Yes, thank you for that. I think that's it for now.
Awesome. Okay. So I wanted to just present a couple of patient cases, but I have talked a little bit more about this than I was planning to. So, like I mentioned before joining academia, I was in a warfarin clinic. So I served about 500 patients across East Texas and South Texas with that medication. So sometimes these visits were face to face, and actually most of them weren't. So our patients could go to a lab and get their labs drawn there. I would receive that lab in the computer and it would prompt me, tell me what that lab value was, and then I would call the patient to follow up with them based on that lab result. So, kind of to explain a little bit about this, I have to explain a little bit about the lab work and what that looks like. So, to monitor warfarin, you must draw an INR, so the International Normalized Ratio. And most of the times, like if you were to take my INR or Justine or Jennifer's INR, it's going to be a 1.0. Okay, that's the standard time it takes for our blood to clot. So a normal person not taking any blood thinners, you can expect their INR to be 1.0. But for our patients that are on blood thinner therapy, they might be on that blood thinner to prevent a blood clot or to treat a current blood clot. And so we want their blood to take a longer period of time to clot. So we want their INR to typically be 2.0 to 3.0, meaning that their blood takes 2 to 3 times longer to clot than a normal person's. Am I making sense? I think most of y'all are following me. Okay. So, I can explicitly remember a few patient cases that I like to use in class. And one of those is demonstrates the importance of communication and the importance of all pharmacies, for all pharmacists working together. So I had a patient who had gone to lab and she had gotten her INR drawn and it came back in my inbox and it was registered at somewhere close to an 8.0. So that 8 is 8 times. So if your blood takes 20 seconds to clot, normally her blood was taking 8 times that. So whatever that is, 160 seconds to clot. So that's like a long time, right? So very critically high. And so I was talking to her and I was trying to figure out why it was so high. So being an anticoagulation pharmacist, you're kind of like a detective. So in pharmacy school, you learn about all of the drug-drug interactions, all of the things that can go on and make an INR high whenever someone's on warfarin. And so I asked the standard questions, did you take extra doses? Have you not been eating? Have you been sick? I went through all the normal things. And everything I asked, she said, no, no, I haven't changed anything. I haven't changed anything. And you could tell she was kind of frustrated. And I was so confused as to why her level was so elevated. And so as I'm talking to her, I finally ask her, what color tablets are you taking right now? And she says, well, the tablets in this bottle are white. And to you, that might sound kind of like, well, yeah, most pills are white, right? But warfarin actually comes in different colors based on their different strengths. And so she was supposed to be using a peach tablet. So a peach tablet is 5 mg and a white tablet is 10 mg. So she had been taking the same amount of tablets of warfarin as she had always taken, and she technically had not done anything differently. but the pharmacist had run out of 5 milligram tablets. So they decided to dispense these 10 milligram tablets. They had updated on the bottle to take half the dose so that it would equal the same amount. But the patient wasn't counseled by the pharmacist, I had no idea it was going to happen, so I didn't know to inform her. And so she had been taking 2 times the amount of warfarin for probably about 3 weeks. And that is why her level was so high. So thankfully, she wasn't having any side effects from this medication, even though her level was dangerously high. So we were able to correct this encounter and figure out, the solution. But just such a big impact that a simple question like, what tablet color, what color is your tablet, that made in her care? Because if that hadn't been caught, then she would have probably continued to take a very high dose. And then in my current practice site, we've already talked a little bit about some medications that we use to manage diabetes. But most recently, I've been doing a lot of continuous glucose monitors and some insulin pumps called Omnipods. So I brought one of the continuous glucose monitors, and I hope this is okay. I did not ask, but I would imagine it's okay. Because it's blurry anyways. So this is actually one of these sensors that go on a patient's arm. And so a big part of my job is educating a patient about how to put this on, connecting the app, and talking about goals. So I kind of wanted to show you all what that looked like today. And that. So you can also see that this is what comes from the pharmacy. So like this is what the pharmacy sees. And if your plan is to go to med school or PA school and be the one prescribing, I highly, highly recommend getting a day with a pharmacist so you can see what you're actually prescribing to your patients, because I think it helps connect it so much. So this is our applicator. So you can see here, there's like a button here and there's a QR code. So whenever I have a patient in clinic, I will tell them to download the app that goes with this continuous glucose monitor, and we will go ahead and connect it right there in clinic. That way, there are no excuses. There's no reason for that patient not to be able to get connected. And then I will actually put this device on them. So let's see here. So when you open up the applicator, you'll see the inside, and it's really, really hard to see on a video. But you can see a very, very small needle. It's kind of long, but it's very, very thin. It's right there. And this needle is not going to stay in the skin. It's going to just puncture the skin so that a catheter can go underneath the skin to measure the interstitial glucose levels of a patient. So super, super cool. So then you choose the place where you want to apply this. So most of these you want to be in fatty tissue or subcutaneous tissue. So a lot of our patients wear them on the back of their upper arm. They can sometimes wear them on their abdomen. Really, anywhere where you think about fatty tissue being, they could theoretically wear these devices, but they're only FDA approved for under the arm, the back of the arm, most of the time. So they would choose their place of application, make sure it's clean, and then whenever you're ready to apply, you press it to the skin where there's no more clear. So you can kind of see there's a clear rim here. You press it to the skin where there's no more clear. You press this button and it pops. It makes a really, really loud noise, and it scares my patients most of the time. And this is applying this sensor to your skin. So I should have brought my demo kit instead of a real one. But then this adhesive sticks to their skin, and this sensor, they're good for usually 10 to 14 days, depending on the brand. And this is going to read their blood sugar or their interstitial glucose every 5 to 15 minutes, again, depending on the brand. So instead of our patients having to do traditional finger sticks where they're having to poke their finger with a lancing device get their meter out, put a test strip in, test their blood sugar, wipe off the blood, get it all cleaned up. And by the time they do this, most of the time they're having to do this like 4 or 5 times a day. So these devices have been so helpful for our patients so that we can monitor their sugars continuously rather than rely on those finger sticks. And so it helps us better manage their medications. So I can look at their glucose levels and actually adjust different types of insulins or their medicines rather than either kind of adjusting blindly, if you will, without the most accurate levels. I'll stop here for a question.
Yeah, Dr. Carter. So you mentioned warfarin interactions.
Yeah.
So how do you actually counsel patients to avoid these situations in real life and
Yeah,
practice?
great question. So I actually am administering on an exam about this tomorrow. So Um, so it kind of depends on the interaction. So if I have a new patient on warfarin, the way I counsel them that there's lots of interactions is I say something like, this medication has a lot of interactions with both prescription medicines and over-the-counter supplement medications. So before you take anything new, I want you to run it by me, another pharmacist, or a trained physician to make sure that it is safe to take. And then, based on the severity of that interaction, determines how I actually go about that. So, a lot of things that interact with warfarin, so kind of just overall big umbrella terms, are antibiotics. So, antibiotics often inhibit the metabolism or the breakdown of warfarin. So warfarin is more active in the body and it's around for longer. So it increases their risk of bleeding or increases their INR, so making their blood even thinner than it should be. So depending on the setting, so if I was, I mean, when I was in the warfarin clinic, I would actually make adjustments to their warfarin dose based on that. So I would say, you know, while you're taking this antibiotic, let's take half a tablet instead of a full tablet. But if I was in the community setting and I was dispensing an interacting medication, I would advise them that this may increase your INR, this could increase your risk of bleeding, and I would recommend contacting whoever prescribes your warfarin. And if it was so significant that I did not even feel comfortable doing that or trust my patient enough to do that on their own, then I would contact the prescriber myself and let them know about that interaction. Great question.
So, as a follow-up,
Mhm.
what are some red flags that you watch for when patients come in that might indicate something like a dangerous drug interaction that they often don't realize they're having?
Yeah. Great question. So whenever I was in the warfarin clinic, I had my students or anyone who was in the clinic with me ensure that they asked the patient 5 questions before they even checked the INR. So one of those questions is, have you missed any doses or taken any extra? Have you started any new medications or supplements? Have you changed anything about your diet? And that's important. That sounds weird because I didn't talk about that at all. But warfarin is inhibited by vitamin K. So if you eat foods with vitamin K in it, it can inhibit the action of warfarin. So it's not that the patient needs to avoid those foods, they just need to be consistent in them. So have you changed anything about your diet? Um, are you having any signs and symptoms of bleeding? And that would be like blood in the urine, blood in the stool, abnormal bruises. So it's kind of expected that our patients bruise more easily on blood thinners because they're taking longer to clot. But if they notice like a bruise that's growing or either in width or especially if it's raised more than normal, that would be considered abnormal and something that we might want to look at as and assess maybe like do they have a hematoma or something like that. And the fifth question is, do you have any upcoming surgeries? Because surgery management with blood thinners is super important because if you're having an invasive surgery, most of the time we want the patient to be able to clot well, right? We're cutting into someone, we need their clotting factors to be up and running fully. So then we would be needed to manage the warfarin surrounding that surgery. Um, does that help answer your question? So by asking those questions, we can sometimes identify if anything's wrong before we even check their INR. And then whenever we checked their lab, we could see, oh yes, this is making an impact, or the occasional, we think it's going to make an impact, but it actually hasn't yet. So we're okay for now, but we may bring you in sooner than later to recheck your blood.
Yeah, that was incredibly helpful.
Awesome.
Feel
Great.
free to transition.
Okay. Thank you. All right. So, like I mentioned, undergrad education, a bachelor's degree is not required for pharmacy school, but so prerequisites can be taken at a junior college or a four-year university. So, I am from Texas, so I have to put my Texas A&M out there. That's where I did my bachelor's. But again, bachelor's is not required. And then PharmD is the degree that you would get in order to practice pharmacy in the United States. And then after you receive your PharmD degree, you take a licensing exam called the NAPLEX or the NAPLEX, depending on who you're talking to. And this is a national exam that you would take in every single state. And then postgraduate training is available as well, such as the residency program I mentioned earlier. So some extracurricular activities that might look good on either an application or really anything that if you're interested in anything healthcare related, and obviously you are because you're coming to pre-health shadowing, but our pre-health clubs. So as I mentioned, I knew I wanted to be in healthcare whenever I was an undergrad. So I was part of like the pre-dent club, then I was part of the pre-PA club. I never was actually part of the pre-pharmacy club because I kind of joined late. But they are often available and it always looks good. They often offer opportunities to do volunteer hours, to do service hours, or even opportunities like this where they might connect you with a shadowing opportunity close to you. So it's a really great activity to do. And then I also highly recommend getting direct patient care hours, whether this be through shadowing or volunteering. So depending on where you're located, what might determine what's available in your area. But you learn so much by hands-on education, which is what I love about this pre-health shadowing. Even though it is virtual, we can still give you a little bit of a taste as to what that career may look like in a day-to-day or year to year. And you can get these opportunities through shadowing or volunteering. It is hard to volunteer in a pharmacy since most of the time you do need like a license to do certain things, but sometimes they will have certain clinics, meaning like a vaccine clinic or some sort of community outreach opportunity that they would be happy to have a pre-pharmacy student or a pre-health student help with volunteering there. And then extracurricular activities, employment is really important, and that you can become a pharmacy employee before pharmacy school. So, like I mentioned, myself, I never set foot in pharmacy during undergrad work. But my husband, he has been a pharmacy technician since his senior year of high school. So he was able to go be a pharmacy technician for lots of years before going to pharmacy school. And that just solidified and confirmed his desire to go into pharmacy. And then lastly, there are some internship opportunities, and that is where I kind of wanted to talk about our Harding specific programs. But I will pause here for a question because I don't want to miss anything.
Yes, episode would you like to go?
Yes, ma'am, I was just interested in the previous slide, please.
This one?
Yes, this one. One more,
Okay.
please.
Yeah. So this is just where I went to school, these pictures. But this is kind of the education that's required for either pre-pharmacy or becoming a pharmacist.
Thank you. Thank you.
Yes, sir. Does anyone have any questions about like postgraduate training available? Okay, perfect. Okay, so this is just a little bit of a picture of what our admissions process looks like. So our prerequisite courses, I had earlier kind of just in umbrella terms, so mostly math and science. So you can see here like 16 hours worth of chemistry. Organic chemistry is typically a sophomore level class, and that can be kind of a rate limiting step to getting into pharmacy school. Biology, 8 hours of biology in some form or fashion. We also at Harding do require microbiology. So there are I think two major areas that pharmacists can make a huge impact in, and this is cardiology and infectious disease. So having a really thorough knowledge of microbiology and then later what antibiotics work on those uh, microbes are is going to be super, super helpful. Math is going to be a big prerequisite, 4 to 6 hours of like calculus or things like that. And then 6 to 8 hours of other maths or sciences. And then general electives of 6 to 8 hours, which must be made up of these others kind of social sciences like psychology, English, or economics. And then so then you would apply to pharmacy school once you are getting close to finishing these prerequisites. You can go ahead and apply before you're finished, as long as you will finish those prerequisite courses by the time you are admitted to pharmacy school or enrolled in pharmacy school. So after you apply and your application is reviewed, you may be offered an interview, and interviews are going to look different at every pharmacy school across the nation. But ours, it looks like a multiple mini interview process. So those are scenario-based questions where we give you like a scenario, and it's more of a behavioral type question. It's not necessarily your typical tell me your strengths and weaknesses interview question. It's more of we give you a scenario, what would you do in the scenario? And there may be more than one right answer. And so we're kind of just looking for your critical thinking process or potentially even your communication process. How well do you communicate your thoughts to us as well? We've recently kind of changed a little bit about our interview process, and I really like what we're doing. So, if you're interested in learning more about Harding's specific interview process or our program, I'd be happy to chat after this presentation. But something else I kind of wanted to talk about is a pre-pharmacy internship that our school specifically offers. And it is, to my knowledge, the first of its kind in the nation. And this is a really cool opportunity to where students who are interested in a career in pharmacy, but they're still in their undergraduate work, can gain valuable experience and they can get hands-on pharmacy experience in Searcy, Arkansas, whether this is with faculty members at their practice sites or in collaboration with Walgreens. So Walgreens offers a few different sites where our students and interns can get exposed to community pharmacy and seeing all that that has to offer more than just the dispensing role. And again, this is designed specifically for undergraduate students, so we don't expect you to have any pharmacy experience at all. And the objectives are listed here where what we're trying to accomplish through this internship. So we want you to gain practical knowledge and hands-on experience. We also provide mentorship through our faculty members. So you get to talk about life. We get to talk about where you want to go professionally, create goals, things like that. We also are able to create networking opportunities through lots of different events. So specifically in Arkansas, we take our interns to the Arkansas Pharmacists Association meetings. So you get to see all of the pharmacists involved in advocacy for the state. And then we also bring in certain guest speakers that are really important national representatives to pharmacy. So I mentioned at the very beginning of this presentation the expansion of pharmacy roles over the past few decades, and those national representatives are a huge reason as to why pharmacy has expanded so much, and we bring those people to Harding, so it's really awesome. Um, we also foster professional development. We offer a few things like CPR certification and other various certificates based on your track, and as well as offer 2 hours of internship coursework that can be transferred back to your four-year university in in the United States. And then we also are going to discuss community engagement. We do a lot of community service based on our practice sites as well. So this is just a few pictures of our two previous internship cohorts. So Enoch Anso was one of our interns last year. He's who connected me to the pre-health shadowing call. So I wanted to kind of give him a shout out. And these previous interns are now either in pharmacy school or they are in the midst of applying to pharmacy school. And some of them decided pharmacy wasn't for them, but they were able to pursue other healthcare positions and said that this internship prepared them really well for it. So some benefits that you get from this internship, besides these awesome fun experiences, are things like free housing. We provide housing on campus. So it's an 8-week program where you would move to Searcy, Arkansas for the summer. We provide housing for that. It is a paid internship. So if you are working in a Walgreens, you're paid by Walgreens at an hourly rate. Or if you're working on the Harding track, then we pay you kind of more of a stipend type payment. And then again, those benefits of helping you with pharmacy school applications, professional development, mentorship. I'm still in touch with a lot of these interns today. Just wrote a letter of recommendation for one earlier for another internship opportunity. So it's a really great program. And if you're interested in learning more or applying, I have the QR code here that I'll put up here in a second. Forgot I had this slide up here. So this kind of just explains which tracks of the internship expose you to all of the different areas of pharmacy that we've discussed tonight. So both tracks are going to expose you to community pharmacy, whether you're in a Walgreens store or if you are at Harding. We place you in an independent community pharmacy to see what that looks like. Hospital pharmacy, we have HUCOP faculty, which is Harding University College of Pharmacy. We have Harding faculty in critical care, cardiology, as well as family medicine or internal medicine. And then you also get to receive your pharmacy technician license through this process as well. I talked heavily on ambulatory care, and if you heard Dr. Jones's talk yesterday, she's also one of the faculty members in this program. And then our last benefit of this program is that you get to participate in a longitudinal research program or project. And so we've done lots of different things with our research. Most recently, we've done research on heart failure, so the clinical impact pharmacists can make in heart failure guideline-directed therapy management and outcomes. A couple of interns last year or this past summer rather, researched the impact of honey and its antimicrobial effects. So that project is still ongoing as well. So super, super cool things that we've been looking at and hope to see in the future. So again, if you're interested in applying or learning more, you can scan this QR code and again could take any questions at that time. And so, in summary, clinical pharmacy is a really, really interesting area of healthcare. It's growing every day, and we have lots of different areas that you can go into. And I only touched on a very, very small amount of what you can do as a clinical pharmacist. There's still so much more that I didn't even discuss or touch on. So if you have any other questions, I'd be happy to take those now.
Yes, Dr. Carter, I see a question in the chat by Neil, and it's asking, what are the best internship options for a high schooler?
Great question. So for a high schooler, depending on where you're located, the best internship opportunities would be for pharmacy specifically, would be more for shadowing. There are a few pharmacy camps around the nation. Harding also offers one of those, and that's kind of like an internship, but it's just it's a shorter amount of time. So it's more of a summer camp that exposes you to pharmacy. You get to compound things. Kind of listen to several presentations, kind of like this, different pharmacists in different areas. And then if you are still in high school, if your high school offers pre-health opportunities like HOSA or anything like that, uh, several pharmacy schools are usually involved with HOSA and um, can provide opportunities to introduce you to pharmacy as well. Good question.
Thank you for that. And I also see another question by Avisoy. So, do you put your patients through drug gene screens? And how long have you been utilizing these screens?
Great question. So in my current practice, we don't actually use any gene screenings regularly. So patients can do these gene screens at out of pocket or in different places. Um, and there are pharmacists utilizing these gene screens in ambulatory care clinics to best manage drugs, even drugs such as warfarin. But I have never been in a place that does them regularly. It's a great question, though.
Yes, thank you. A question from Tegan. I hope I said that right. In what ways do you interact with psychiatrists if you interact with them at all?
Great question. So I am currently in a teaching clinic. So it is a family medicine clinic. So primarily, I have 18 family medicine residents physician residents that are practicing in the clinic. And we do have a psychiatrist resident as well. And so they are in the clinic like once or twice a week. So I occasionally will discuss patient care with them. Like if we have a complicated patient with a lot of drug interactions among psych drugs, we'll work together and brainstorm the best plan for them. Um, but I will be honest, and psych is not my area of expertise. So I don't really interact with them as much um, as some other pharmacists do.
Another question by Avisoy. So, are you concerned that your patients may not be getting the best personalized care with drug gene screens?
Because I'm not doing drug gene screens. I I occasionally would be worried. Um, And for those patients that I would be worried that that medication isn't working for them, then I would likely recommend they get those screenings done. However, there's not a lot of guidelines directed management with drug gene screens out about everyday medications. So I've never really worked in a setting that would be needed to do that. So all of the medications that I use every day in practice and manage can be monitored through other means. So, like I said earlier, like with warfarin, um, you're monitoring its efficacy via the INR. So I was able to show that this medication was being effective for them. And while having the gene, like knowing their genotype may have been helpful for me on the front end, like, oh, this patient is going to metabolize this slowly. I need to give them a bigger dose. I ultimately am going to learn that through monitoring of the INR. Vice versa with insulin. Insulin really isn't that is not really going to impact them a whole lot, as well as other diabetes medications. So I'm monitoring its efficacy or their efficacy through blood sugar levels, their time in range, the continuous glucose monitoring levels. So I'm not personally worried that they aren't receiving the most individualized, personalized care, but that also is just my area of practice as well. Good question.
Justine, would you like to go next?
Yeah, so I had a kind of different question that involves the interview process. I was just curious if there was ever a wrong answer to answering an interview question, or more like, what if someone has a really great background but explains themselves with like a broader approach to that question? Like, what
Yeah,
would that sort of assessment be like?
that's a great question. So, um, there aren't, there's lots of right answers. So some of these questions are kind of like ethical questions. So if you are saying something completely ethically wrong, then that would be a kind of a red flag. I would imagine that most of y'all on this call would answer any question really well. If you can't communicate super well, that's okay. Or if you kind of go at it at a different angle, our faculty members are the ones interviewing you, and we're likely going to probe you to try to either further explain or go down a different road if we want you to give us more specifics. So we try to have a lot of grace. We try to give you um, a lot of opportunities to best answer any question that we may ask. And that's what I love about our new interview process is we've introduced a few what I call casual interviews. So not only are we just pestering you and pelting you with the behavioral scenario questions, we're getting to know you as a person a little bit better during that interview process as well. Great question.
Thank you.
One question I had for you, Dr. Carter, was where do you see ambulatory care pharmacy heading in the next decade?
Oh, good question. So I hope to see it just continue to grow. And as we continue to see more pharmacy-friendly prescribers, such as physicians, nurse practitioners, mid-levels, I can only hope that we'll start seeing a pharmacist in every clinic. That's what I would love to see is a pharmacist in every clinic, whether that's doing the gene screening that's been mentioned or just evaluating for drug-drug interactions on drug lists or doing something a little bit more specialized like what I've done with anticoagulation or diabetes management. Um, and then I also would love to see better reimbursement for those ambulatory care pharmacists. So right now, because we're not recognized as federally uh, qualified providers, there's certain limitations to what we can bill and earn for a clinic. even though our value-based services provide just as best outcomes as others services. So being able to bill for those services and actually generate revenue and for our clinics is something I would love to see happen in the next decade. Great question.
So, what additional responsibilities do you think ambulatory care pharmacists will gain?
So something that I don't know that was explicitly explained is so I've been able to work under collaborative practice agreements. So these collaborative practice agreements are different. They can be different levels. So I've always worked under one that allows me to prescribe. So I've had prescriptive authority of whatever medications I'm allowed to prescribe. Um, so maybe removing some of those limitations. So not necessarily adding more responsibilities to the pharmacist, but just allowing us to do those without so many restrictions, I guess, is kind of what um, I would like to see with that. Does that answer your question?
Yeah, that answers my
Okay.
question. Thank you.
Mhm.
Um, and what excites you the most about the future of your field? Is there anything like that?
Yeah. So that's what I love about being a pharmacy educator. So do I just think our future generation of pharmacists are going to do great things. So where you just asked me that question of where do I see AmCare in a decade, I know my students would have way better answers than what I just gave you. And they want to do more and they uh, they have a better voice than what we've had in the past, and they know how to use that voice. And so I'm really excited. This is why, like I said, it's why I love being a pharmacy educator, seeing their brains, their eyes light up whenever you say, this is something new and we're going to learn and tackle it today. And then they want to take that and run with it. So that energy excites me for sure.
So, as you mentioned that your students might have better answers and maybe like a different perspective to the questions I'm asking. So, to these like upcoming changes and in the future, how are you preparing yourself or your students for these changes?
Great question. So I do try to make any of my curriculum forward facing. So I um I recently became a professor. So it's been within 2 years that I became a professor. So anything that I teach, I try to make it applicable for years to come. So, which is hard because medicine is ever changing. So, I think just making sure that I tell my students this is ever changing. I'm teaching you the most up to date right now, and these are my ideas, but that is not the only way or like to go. Of course, there's the right answers clinically. I mean, there's medications that are better than others, and you have to know which medication works in a different way or whatever. But as far as like guidelines or what we're allowed to do right now, advocacy, that kind of thing, our students rather, um, I want them to have like the I want them to feel empowered to take this knowledge at one more step. So, for example, in my communications course, the patient counseling and communications course I mentioned earlier, I try to come up with scenarios of things that they might experience as a pharmacist. And we kind of do some role play with that or reflections with that. And then I may have them come up with something themselves. Or I kind of just get them thinking, like, okay, so AI is a big thing now, right? So I don't really know how that's going to play into the role of pharmacy in the future. We are already seeing some AI tools come out and being used in pharmacy settings or hospital settings, especially. And so I may not have like a good example for the student to say, like, this is how we're doing this now. But I say, hey, I noticed this new tool came out. what do you think we can do with this in the future? And so getting them kind of thinking about that, because I know that if we don't learn like we're going to work in the future, we're going to get left behind, right? So try to prepare our students for that.
Yeah, I really like your approach of getting the students to actually think about the upcoming situations and getting their insights and just trying to build their perspective early on.
Mhm.
Um, Apart from this, what new skills would you recommend that current pharmacy students focus on developing?
It's a good question. So, I mean, I feel like I'm talking to the cream of the crop. So all of y'all are going to be wanting to study and wanting to learn more all of the time. I think one of the skills that's really, really hard to teach in a classroom is initiative. So being proactive in your learning, kind of like what we've been talking about, being proactive, being taking initiative on taking the next step. Like I said, it's really hard to teach that in a classroom, and it's hard to make that like an expectation of the student per se. Um, but so if you're interested in becoming a pharmacist or you know you're going to pharmacy school, taking initiative to go find a job, to go find that internship opportunity, to read that article about the new gene screen that you heard about on the news instead of just relying on the news to tell you all of the truth, right? Um, and then coming prepared with those questions to your professors or your mentors, rather than just asking those questions. So that's kind of hard to understand until you're in a pharmacy and you have like a fourth year student who's just asking you questions and you're like, you can go look that up. You can take initiative to go do that and learn about that yourself. And then you can come back to me and we can discuss and have a really, really robust discussion. But if I just tell you the answer, you're not going to get as much out of it as if you do some research yourself and and start thinking about it critically yourself. And then we can, again, have those discussions. You're going to learn a lot more from that. So I guess just taking initiative, being proactive in your learning is a huge skill that I see. It makes you stand apart from others for sure.
Yes, thank you so much for that. Um, I see a question by Absolor. So, as a lecturer, do you oversee any laboratory practicals?
Good question. So I don't oversee lab practicals in the way that you probably are imagining them. So in undergraduate work, your labs are like legitimate labs, right? Like you're in the chemistry lab and you're mixing things in beakers and doing all the things. So I do more practical labs, which you're like, that sounds the same thing. But mine are more scenario type based. So we call them OSCEs, so obstructive structured clinical examinations. And these are things that assess your clinical knowledge in a practical way. So I mentioned kind of some scenarios that you could play in. So like in my communications course, I have a community pharmacy scenario, a hospital pharmacy scenario, and a ambulatory care pharmacy scenario. So I bring in actors and they act, and the students are expected to play the role of a pharmacist. So in those community roles, they would be counseling on a prescription, dispensing that medication, things like that. And then the hospital pharmacy, they're talking to a doctor about a prescription, or they're acting as if they're rounding on a team. Um, in the ambulatory care pharmacy, they may be talking to someone about putting on a CGM and then talking to the prescriber. So it's a lot more practical. And I'm mostly teaching first year students. So it does advance as the curriculum goes on. So in the second year, we kind of bump those OSCEs up a level where instead of just saying, um, this is an ambulatory care setting and where I'm going to give you the scenario, you may not know the scenario until you walk in the room, or you are given more of a clinical case, a clinical question that I wouldn't expect a first year to know, but I do expect my second years to know. Um, so different. I don't oversee any labs in like compounding wise, but we do have compounding labs where you're expected to um, create different pharmaceutical items, do different recipes, and make those. But those are more overseen by our basic sciences or our pharmaceutical sciences departments. Good question.
I know we're a little over time. Maybe it's a last question because we usually always get this question is if someone was going to go into pharmacy, what kind of advice would you give them in terms of applying or what they could be doing to make themselves a better competitive applicant?
Yeah, great question. So of course, grades are important, but grades are not all, right? So I'm looking for more of a well-rounded candidate. So by well-rounded, I mean, because you can have a 4.0 and that's awesome, but you can have a 4.0 and you lived in the library the entire time you were in school, which means you may not know how to talk to people super well, or you don't really have like the hands-on practical skills that are we're looking for in a pharmacist. So those extracurriculars that I talked about, the pre-health clubs, service work, involvement in a social club I mean a church or some sort of like social environment, I think is really important because being a pharmacist, you have to have great social skills, communication skills. You have to be able to read your patient or know how to speak to a prescriber. And in order to do that, you also have to manage a lot of things. You're managing a lot of things. So if you can show me that I can maintain a good GPA, definitely want to maintain a good GPA, but I can also hold a conversation. I also have other values that I think are important and I devote my time to, but I still can manage my time well. Employment, internship opportunities. Obviously, we would love if you came in with any pharmacy experience, but I'm a live example of like it's okay. You can also survive without that in pharmacy school. But work hard, study hard, um, and and you will do well. Good question.
Any final questions before we start wrapping up? Okay, I'm just gonna present my screen.
Oh, yeah, sorry.
Okay, so three reflection questions that we have for you today are what was your favorite moment or example from today's session? What's one idea from today that you're most excited to explore next? And what's one key takeaway or idea that stood out to you the most? Feel free to answer these questions in the chat or on the PHS website. And feel free to share your insights about today's session on LinkedIn, and you can just tag us at rehouseshadowing.com, and we really look forward to it because they're really helpful. Once again, if you're interested in being part of the pre-hot shadowing team, you can work with us remotely, you can volunteer or apply for the leadership team, and it's a 100% remote. So you can just do it from the comfort of your home and just head to the pre-hot shadowing website if you're interested. And if you can, please consider donating. But we understand that some people cannot donate, but you could also help us by volunteering your precious time with us, and because these two things are the foundation of PHS. Don't forget to take the post-shadowing assessment today, just so you can get a certificate for all the time you dedicated with us today. And if you missed a part of the session today, no worries. You can just head to our YouTube channel at Pre-Health Shadowing and watch any of our sessions for free. Make sure you subscribe to our calendar so you don't miss any upcoming sessions. And thank you so much. And if you have any questions, feel free to stick around and ask your student team.
Thanks so much, Dr. Carter.
Yes, thank y'all so much for having me. This is great. Y'all have a good evening.
Yeah, you